concept moving forward for stratified diabetes medicine. It would be this concept from Dr. Paul Franks that was published over 12 years ago that basically looked at the interaction of what he determined the non-genetic elements to which we are exposed: stress, medication, obesity, smoking, and the interaction with the physiome, which is what you've talked a lot about this today. The genetics, the epigenome, the proteome, the metabolome. And that interaction between the exposome and the physiome, if we could understand that, that will hold the key to understanding stratified diabetes medicine at the clinical level. Now, it would be hard to, when we talk about this, we really define precision diabetology. And really that's what the goal and the objective and challenge is really to develop this stratified prevention and treatment for subgroups for people with different risk profiles. And you've heard a lot in this session today. And if we can get to precise therapy, there will be fewer adverse events from pharmacotherapy, delay in onset of diabetes and complications, decreased morbidity and mortality, and decreased cost of care. Put it simply, the challenge right now for heterogeneity in precision medicine is matching the right drug to the right patient at the right time for the best clinical outcome. But here's the issue. What we've heard over the past symposium and the last couple of days is the current classification and the heterogeneity of the disease. Clearly, we have type 1 and type 2, but this is a really dated classification. We can go back to 1939 where type 1 and type 2 were beginning to be separated based on insulin sensitive and insulin insensitive conditions from the oral glucose tolerance test. The current nomenclature comes from 1979 from the National Diabetes Data Group and the ADA, and 1985 from the World Health Organization. But as you know today, you've heard a lot about other types of diabetes. We've heard a lot about monogenic diabetes. The first term was used in the 1970s. The molecular underpinnings beginning to be understood in the early 90s. We have latent autoimmune diabetes of adulthood, first described in 1996. And as we've heard today, there is diabetes related to lipodystrophy, diabetes related to pancreatitis, post-transplantation, cystic fibrosis related diabetes. When we even consider type 2 diabetes, there's differences between youth, adolescents, and adults with different pathophysiology. There are different subtypes of type 2 in adults. I know over the last couple of days you've talked about the lean BMI diabetes, particularly in India. And what we're studying in this country is new diabetes that may be related to COVID infection. So based on this heterogeneity, you could understand there's confusion as far as the most appropriate treatment for the majority of the patients. Now, unlike what we've heard earlier in the previous sessions, monogenic diabetes can be a single gene disorder. And based on that, we can get precise medical approach. But for type 2, we know it's a complex trait. Multi-tissue dysfunction, contributions from pancreatic dysfunction, hepatic glucose, inflammation, the environment, insulin resistance, and obesity. So it's a multi-tissue dysfunction. But today, we define and diagnose this condition with one glucose marker, biomarker, and that being glucose. And yet, we treat individuals with diabetes based on average treatment effects from glycemic levels in multi-clinical trials. There's no really consideration for the underlying pathophysiology when we treat. So I'd like to share with you now the concern that we have with heterogeneity and treatment heterogeneity. And this was a nice study done a couple of years ago by Thomas Peterson and group at the University of California, where they looked at the University of California system with electronic health records and able to track treatment patterns. In fact, in this particular study, they looked at over 5 million patients in the University of California data warehouse. And they were able to find over 97,000 type 2 patients and over 1 million medication orders. So they use lifesaver plots. And let me take, for example, this first level. So as you can see this first circle, the color indicates the monotherapy used by the physician. If it's a different color, it was a different initial therapy. But you could see just from this lifesaver plot the various therapies used as the initial suggested therapy. Now, as you go to the second lifesaver plot, each particular radius is a patient. And if the color changes, that means they detected a medication change. So by the time we get out to the third and the fourth medication change, what you'll notice and what they found was this, that even tracking the first 4 medication changes for the 97,000 patients, they identified over 12,000 unique treatment trajectories. And their conclusion was treatment of diabetes in the real world has tremendous heterogeneity in practice patterns. Now, this is not hard to understand given that the physician and the provider reacted to what they understood as the underlying pathophysiology, particularly for type 2 being a very complex trait. Now, so what is the problem we're trying to solve? Well, suboptimal management of diabetes leads to complications and reduced quality of life. And currently, the strategies for treatment are based on average treatment effects. One size does not fit all. Treatments are not targeted individuals with the specific genetic, physiologic, and phenotypic features, as you've heard in many of your sessions. Marked heterogeneity of the disease exists to clinical presentation, risk factors, diverse outcome, and disease course. And the concern is right now we're using glucose as the sole biomarker for a complex condition of type 2 diabetes, again, based on defects in secretion, the environment, hepatic glucose production resistance. And so over the past many years, there's been interest in trying to better define type 2 by using clustering of variables. I'm going to give you some examples today as to how that has worked. So we all know one of the classic studies, landmark studies, is the ALQUA study, where in their Scandinavian cohorts, they looked at 6 cluster variables, GAD antibodies, age, body mass index, hemoglobin A1C, insulin secretion, and insulin resistance. And they were able to show that there were at least 5 subtypes. The severe autoimmune diabetes, GAD antibody positive, poor metabolic control. They defined a severe insulin deficient diabetes, low insulin secretion, increased risk of retinopathy. They defined an insulin-resistant disease, diabetes, which had a marked increase in nephropathy. And they defined a moderate obesity and a moderate age-related diabetes. Now, the importance of this study was that they were able to show that these subtypes did indeed relate to clinical outcomes. So identifying someone early and knowing that those variables can predict a complication is very powerful information. So for example, the severe insulin deficient diabetes, the highest rate of retinopathy, the severe insulin resistant diabetes, the highest rate of liver disease, the highest risk of chronic kidney disease. Now, these subtypes are not perfect, but what the data did do was suggest that the combined information from a few variables is central to the development of diabetes and superior to the measurement of one metabolite, glucose. Now, these particular subgroups have actually been validated in cohorts around the globe. Not perfect, but showing that this concept is a very good start in classification, or at least identifying some subtypes. Interesting, when we look at some of the global cardiovascular trials, DEVOTE, LEADER, and SUSTAIN, using this concept of subtypes actually showed a difference in some cardiovascular outcomes. It showed some difference in some renal outcomes. So the proof of principle that these subtypes may be valid has been shown from many of these studies in the literature. Now, an interesting study from Robert Wagner's group suggested that you can begin to subtype even at individuals at high risk. And the variables that he used were estimates of secretion and resistance from the tolerance test. Sub-Q and visceral body fat measures, you've heard some of those parameters today. Hepatic fat content, genetic risk, and HDL. So I'm just going to summarize his results. He was able to show that in individuals at high risk, at least 3 low-risk clusters. Clusters that had low diabetes risk and low mortality. But then he was able to identify this cluster 3 that had a high risk, high genetic risk, low insulin secretion, but had a high diabetes risk and a high cardiovascular risk. The authors identified this cluster 5, liver, visceral fat, insulin resistance, a high diabetes risk, and increased cardiovascular risk. But interestingly, a cluster 6, high risk, visceral fat, renal sinus fat, hyperinsulinemia. High risk of all-cause mortality, increased risk of nephropathy, but only a moderate diabetes risk. So what does this data suggest? Well, if we can identify, given the number of individuals at increased risk of diabetes globally and the scarce resources we have, you can imagine if we have a classification system where we can identify those who are not going to proceed rapidly, perhaps we can continue to monitor those. But those who have that characteristics that are going to progress and develop diabetes and complications, once again, this is where we would suggest intervening more aggressively. So when we look at these subtypes, again, one of the concerns are that some of the variables like hemoglobin A1C may change with disease progression. So what do you do in that situation? And can these subtypes now be used for a specific therapeutic decision? And those are issues that still need to be addressed. The other underlying issue is, what is the precise molecular etiology of these subtypes? And here there's been some very interesting data. Over the past many years, there's been some data that some of these subtypes might have specific molecular signatures. I'm just going to give you a few examples. This is the IMI Rhapsody study where they looked at the different subtypes. And then looking at levels of branched-chain amino acids and diacetyl and triacylglycerides, they were able to show that in the severe insulin-resistant diabetes, this subtype had the highest level of the diacetyl and triacylglycerides. But when you look at proteins and the insulin signaling cascade, this is where they had the deficit. Now, when you look at mild diabetes, this had the higher levels of diacetyl and triacylglyceride and the more favorable profile for the insulin receptor proteins, and the moderate had levels somewhat intermediate. Other examples comes from Dr. Herder's group from the German diabetes study that looked at over 75 biomarkers of inflammation and looked at the differences between the subtypes, and after controlling for confounding variables, just demonstrating that there are several biomarkers that appear to be different depending on the comparisons of the subtype. So just suggesting that many of these subtypes may indeed have specific molecular signatures, and that I think is of great interest. Now, up to this point, if we can define heterogeneity better and move to a precision medicine approach, this clearly, you can imagine, will help us with diagnosis and classification, will help us moving forward with better management strategies, would help with more effective prevention of complications, more targeted interventions for prevention. Now, this is a noble aim, but the question we have globally about the diabetes burden increasing in every country. And the question that is asked is, well, will precision medicine address the diabetes burden? And to be fair, there's some healthy skepticism in the literature about precision medicine and how it would address the global burden from a public health perspective. So I'd like to now talk about the difference in our approach to healthcare and improving population health. On one side, we have a very exciting line, precision medicine. It's a micro approach, the unit of interest in the individual, and it focuses on the disease process. From many papers, again, we need a large amount of data, genetics, omics, metabolites, and we apply it to a small number of people. Now, on the counter, public health approach, this is the macro approach. Populations are the basis unit for the intervention. And so in this, the argument is we need just a small amount of data to apply it to a larger population, such as prevention. Now, in the past, we would say, well, it's either one or the other. But the question that has been asked, does investment in precision medicine come at the cost of existing public health measures that could have a greater impact on public health? And I'll give you one example. Let's talk about tobacco. We know we have patches and we know we have medications to crave that will address the cravings. But is that as effective as public health measures that will tax cigarettes, limit where you can smoke, put restrictions and warnings on the packages? So I'm trying to show you the differences in a public health approach to a common problem as provide a precision medicine approach. But can we apply that to the diabetes global burden? Well, let me suggest this. Precision medicine, clearly we need to move forward. But the argument is that, well, we focus on genetic genomic analysis. There's a central focus. And if we focus on technology alone, that could potentially decrease healthcare access and perhaps will reduce healthcare access in at-risk communities in low-income countries. There's an argument that there are narrower endpoints for precision medicine. It needs to be cost-effective. And precision medicine today, the determinants of diabetes globally are rooted in economic and social factors. And we're not considered in great details the environmental factors when we talk about precision medicine. In fact, there are a number of studies that suggest social economic factors may have a greater impact on community health than medical intervention. So what I'm suggesting is this. When we move forward, and we do need to move forward with understanding precision medicine, and getting back to Dr. Frank's slide, this interaction of the non-genetic elements with the quantifiable elements, the human physiome, and that interaction, that is going to be very important for stratified medicine. But it has to be understood in the context of the environment of the individual. The individual as far as healthcare access, neighborhood, economic and social context. So the social determinants and the environment does indeed contribute to this and to the progression of this interaction. So when we talk about precision medicine, again, we've led to believe, and rightfully so, when we need to understand precision medicine, we need to understand the molecular signatures of these subtypes, the genomics, the proteomics, the metabolomics, metabolites. Again, a lot of understanding the underpinnings you've heard over the last couple of days. But this is where it's also important to now, in this particular time and age, in the year 2025, there are laudable wearable technologies where we can get information on physical activity, food choices, sleep, stress, and mood. And then from our databases, understand the conditions and the communities and the environment in which disease develops. And this is where we can really move to more precise interventions. So a nice study that was done a few years ago said that precision medicine and public health, there needs to be convergence. Precision medicine, public health, it shouldn't be one or the other. The argument from this particular paper, very nicely done paper, is this concept called precision public health. And what they're referring to is we take the best of precision medicine, the deeper dive in phenotyping, and we take the concepts from public health and the convergence of big data and analytical methods to analyze the omics, the social factors, the clinical phenotyping, the environmental determinants, patient-derived health factors, the demographic factors, to arrive at this precision public health. And that was felt to be the approach we need to move forward to in the future. So with that being said, the goal here would be better risk factor stratification and more precise management strategies. So this has been of great interest to us. And at NIH and NIDDK, as you know, we have the All of Us program, but specifically in our institute, we're in the process now of developing a roadmap for the next 3, 5, 7, 10 years to address those problems related to understanding heterogeneity and eventually move toward a reclassification in precision medicine. And this means investing in studies at the preclinical level, heterogeneity, molecular cellular level, identifying biomarkers, doing clinical studies to understand the heterogeneity in disease development across the lifespan, investing in diagnostics, sensors, diagnostic treatments, and invested in studies to look at the heterogeneity of therapeutic response. But at the end of the day, all these factors, for them to have a role, these translational efforts have to be disseminated to the bedside and have to be disseminated to healthcare settings, communities, and populations on a global scale. And again, this is not a trivial ask. This is going to take many, many years of funding and organization and outlining these particular projects. So we're about 18 months into our working group structure, and the working group is going to provide recommendations to our institute at the highest level on recommendations, rationale, and scientific opportunities to move forward. And so we will be presenting this report, and we got the first draft this month, and the subgroups that have been involved, engagement, identifying barriers to develop external stakeholder strategy, a preclinical group, a clinical group, lifestyle, and an innovation with technology. And this is going to be blended with our cross-cutting themes, making sure we address health equity, making sure we address data science. We hope to have partnerships moving forward, and again, at the end of the day, cost effectiveness. So we're very interested in this direction at NIDDK and NIH, and we hope at the end of the day, at some point in the future, we will have the goal of precision diabetology and has more stratified prevention and treatment for subgroups of people with different risk. Earlier in the lecture, I said the challenge is matching the right drug to the right patient at the right time for the best clinical outcome. Well, our immediate goal over the next couple of years is to stimulate research efforts to better understand the heterogeneity of diabetes, so we can come to a consensus for these discrete definitions of subtypes of diabetes that you've been discussing over the past many days. So with that, again, thank you for the invitation.
So today what I'm going to share today is about our journey with technology, next-gen sequencing, why we have to adapt this technology, and our lessons learned, the lessons that we learned over the decade. So my talk would cover how we're using technology to confirm the diagnosis, and a little bit on targeted NGS workflow that we've established here, and also how the monogenic diabetes genes, MODY, lipodystrophy, insulin resistance genes, and the way we are moving towards precision diabetes medicine, and a little bit on diagenic MODY that we think is important. And there are also, to support this concept, the ACMG guidelines, there's a lot of extension and added on to add this kind of variance in the ACMG guidelines, and also what is our recommendations. To start with, this was the hypothesis when I started working as a PhD student under Dr. Nihal. So this was, he was interested in young onset diabetes, and our hypothesis was either it could be because of the beta cells. We've been hearing a lot about beta cell mass, beta cell function. Yes, it could, beta cells have quite a bit of potential to compensate, right? You see hyperinsulinemia and type 2 diabetes quite a bit. And the beta cells can compensate. If there is a loss of beta cell function, or kind of it's a development defect, the compensation, the feedback loop can be affected, and therefore early onset diabetes or a low BMI diabetes. Or it could be other factors which influence the insulin resistance, right? The lipodystrophy, insulin resistance genes, and so on and so forth. So that's how we ended up looking at monogenic diabetes. If you look at here, the monogenic defects for beta cell function, which includes MODY, around 14 different types, and also look at the monogenic defects in insulin action and other syndromic forms. So the question that we had early on was, when we started our work in 2011, if you see all the groups across the world, they were looking at only MODY 1, 2, and 3. And the first question that I asked Dr. Nihal was, how do we know that these are only 3 genes? And Dr. Nihal said, yeah, that's a very interesting question. I don't mind you doing 10 genes, 20 genes, 30 genes, but you need to get the cost down to less than 10,000. So that was a challenge that he posed. And also there's a lot of bit of overlapping clinical features, right? And also the cost was huge. And because of this, many of these patients are misdiagnosed and may be receiving inappropriate therapies. Early on, we realized if you have more than 10 genes, Sanger is not the method. And we were looking at technology, and exactly at that point, the next-gen sequencing technology there was a lot of improvements, and there was a benchtop sequences that were launched. And we chose a semiconductor chip-based system, which is like a massive parallel sequencing. Next-gen sequencing is nothing but you sequence millions to billions of fragments parallelly. Therefore, you can sequence multiple genes, multiple samples together. So the systems which use a glass slide, but we chose a chip-based system, and this is one of the first NGS labs in a hospital. In 2011, I'm not sure how many hospitals had this system, but we think that we are one of the first labs in a hospital to have this technology. And it uses a semiconductor chip, and there are 1.2 million wells to 154 million wells, and therefore you can sequence millions of these fragments. However, whenever you're getting a technology into a clinic, you can't just use it. You need to establish the protocols, you need to benchmark it, and that's what we did early on. And so we developed our own methods here, especially if you want to use NGS. The first step is target enrichment. So we need to amplify those targets. And the commercial kits costed somewhere around $150 to $200 when we started our work. So we quickly realized there's no way that we can put in that much amounts of money or our patients can afford. So we developed our own multiplex PCRs, and so we amplify all the MODY genes using these multiplex PCRs. We pool them, we prepare the libraries where we index them. So once you index, you can put multiple samples, and we perform an emulsion PCR where every single fragment gets amplified on a bead like this, and we load on the chip. And post-sequencing, you see that there are multiple sequences. So based on the indexes, they get separated out, demultiplexed them, and then when you compare them with the reference, you'll be able to pick up the variants. And we classify the variants based on American College of Medical Genetics guidelines, and the variants that you think that based on these guidelines, we find it as pathogenic or likely pathogenic or any novel variants, we confirm with Sanger. So at the end of our 1.5 years of efforts, we realized this is a very sensitive and specific method, and we could use it in a clinic. And from this, we have actually used it in many of our studies. I'm just presenting here some of these papers. But the most important paper that we published, we think, is and a highly cited paper in India is this, where we found a spectrum which was not just MODY 1, 2, and 3. And later studies, and there are enough studies now backing us up that it's not just MODY 1, 2, and 3. There could be other genes as well, right? So these were the variants. I'm not going to spend much time here, but quickly, after this study, we also got a DBT funding where we collaborated with MDRF and other center, where we were able to actually lead a study across India, and I think we've screened one of the largest number of patients in young onset diabetes. And so I'm going to just give you a snapshot of this data. It's not the comprehensive data, but a snapshot to help you understand what is the spread across. So before that, I just want to mention about how the classification works. Based on American College of Medical Genetics guidelines, if you have kind of evidences where you can classify the variant as pathogenic, meaning it's segregating with the phenotype in the family, or you have functional assays, you classify them as pathogenic or likely pathogenic, and or benign when you have clear evidences not segregating, and so on and so forth. However, if you don't have any of these evidences, it falls into some category called variant with uncertain significance. The larger the panel, the bigger the panel, you see a lot of VUS coming in. So I'm going to present the data for just pathogenic and likely pathogenic, and then later I'm going to also present as including VUS. So just let's look at how the data looks. So this is the data that we have now. So we have around 50 plus variants now, which are definitely pathogenic and likely pathogenic. And if you see from the Western data, the MODY types, the GCK is the top gene, which is kind of is found in Western data. Whereas in our cohort, it is 1 alpha and ABCC8. And other genes in the West are HNF1 alpha and 4 alpha, whereas we have a spread across. And even Dr. Mohan and Dr. Radha also published their data in 2018. And they also found a similar, when they looked at 121 targeted exomes, with basically a virtual exome, where they looked at these genes. They found that ABCC8 and HNF1 alpha and ABCC8. So this shows that HNF1 alpha and ABCC8 are definitely the top genes in our country. But still there are other genes, and GCK seem to be much lower, but still there are considerable number. So we're looking at strategies how we can pick up even these rarer forms with at a higher rate. So I'm just going to present data for GCK. If you look at these the data here, there's something called positive predictive value. We were intrigued to see this because all those patients who were GCK positive had a probability score above 75. And so, so we just categorized them based on those who had this, where we could generate this positive predictive value. This positive predictive value is generated using a Modi calculator. It is freely available and developed by Exeter, Diabetes Center UK. And so you can use this, you can enter the data and you get a score. And using this score, we classified our data and we looked at those who were 70, there were around 108 patients who had their probability score above 75, and we found 6 out of 108 were positive. So meaning, by looking at using this tool, you may still pick up, even though GCK Modi is rare, you can use tools like this to pick up GCK Modi in our country. And other interesting thing is none of those who were less than 55 were positive. This is also very interesting. And also there's already published data. When we're looking at the literature, we saw that there's already data published from Turkey where they've screened for Modi in Turkey, and they found 13 out of 54 were positive, but out of them, 12 were actually had patients who had Modi probability score above 75. So this is almost like confirming, like, yes, this tool may be utilized to pick up GCK Modi even in our patients in India. So if you see the relevance of this is, once you have a confirmed diagnosis, you can manage GCK Modi, can be managed with diet and exercise. I'm sure many of you are aware of this. And not only that, there's a 50% chance of inheritance to the next generation. And if you have a GCK mother and fetus is negative, they may you can see an increased fetal growth, which can be picked up in at the end of first trimester imaging. And it is recommended to treat with insulin during pregnancy to avoid macrosomia. And 1-alpha, 4-alpha, they respond to they respond very well to low dose sulfonylureas, and 1-beta requires insulin, and so on and so forth, right? So this is, this is now well recognized across, where we have GCK with diet and exercise, 1-alpha, 4-alpha, low dose sulfonylureas, ABCC8, KCNG11, neonatal forms of diabetes require high dose sulfonylureas, whereas Modi kind of picture young onset diabetes require varied dose, 1-beta require insulin. Other forms we are not very sure, but still hopefully in the near future we'll have more of these precision medicine possible in these forms as well. So we finished doing our Modi workup for the 14 genes, and we found there was considerable numbers who were negative. And here is a case, I'm just kind of citing one case here where we found this patient to be negative for mutations. And however, he had an elder sibling who was also diagnosed at the age of 9, and they were born out of consanguineous marriage, and therefore we thought there may be some recessive form of disease here. And this, interestingly, this case was also sent to an external lab, commercial lab, and they gave a negative report. But however, we did process this, and we found a WFS1 gene mutation in this patient. And the elder sibling also was positive for homozygous WFS1 variant. And the parents were heterozygous carriers. So normally you see frame shift mutations or truncating mutations causing WFS1 when Wolfram syndrome with a classical Didmod phenotype. But here we see just diabetes. We're not sure how the patient is going to progress, but we can pick them up that they are not type 1, right? And also we found another interesting variant through these investigations, where there was a young patient with diabetes where we found R558C. And if you see the variant classification based on just allele frequencies, you just filter such variants. But actually when we did a segregation family screening, we actually found that this variant is segregating with young onset diabetes. And so, and after a couple of years, in 2018, the data came out from Ashkenazi Jewish population. They found that this variant is, the frequency is around 1.4% of these individuals actually carry this. And when they screened 475 type 1 diabetics, they found 8 homozygotes. And not only that, those heterozygous carriers were at higher risk for type 2 diabetes. So based on this data and our experience over the years, what we think is there are some of the functionally important variants maybe enriched in a population. If you see our population, our subjects here, you see that age and BMI matched Indians are at 3 to 4 times more prone to diabetes. Maybe some of these variants which still need to be figured out, right? So fortunately we actually published a series with a range of phenotype from classical form where we found a founder mutation in 3 individuals, and also truncating mutations, non-synonymous, to heterozygous variants in young onset diabetes, and this was published in JCM recently. And the WFS1 is very important because we now know that the underlying molecular mechanism is there's built up of ER stress in the beta cells, and there are also other neurodegenerative disorders where ER stress is the cause. And now FDA started giving orphan drug status to these drugs to be utilized in WFS. So it's very interesting if you can pick the patients in the first decade. At the onset of diabetes that they are WFS1 mutation positive patients, you can evaluate them and see if you can improve the quality of life, right? And also there are other groups which think that GLP-1 receptor agonist may be a good option to be evaluated in this group. So till now I was just presenting on variants which are pathogenic and likely better. But when you bring in the VUS variants, you see that the spread is totally different. You see ABCC8, PDX1, 1-alpha, and also PAX4. So I'm just going to see the spread, how they are across. If you see 1-alpha, 4-alpha, and GCK, you see the blue bar is high, right? Maybe these are well investigated and you have enough data to prove that they are pathogenic. Other forms are hardly studied. Or they could be low penetrant variants, many of these. So we need more investigations in this. Further, we found through our first set of investigations that we found there were 2 patients who had NeuroD1 and PDX1 combination. MODY is monogenic, but we found 2 patients to have this combination. And interestingly, when we did a string analysis, we found that actually they interact and have an influence on insulin gene, and the data was there already. And the data is that if they form a complex, NeuroD1, PDX1 form a complex, and is required for insulin gene looping and expression. So we said, okay, if that's the case, the insulin levels should be much lower in these 2 individuals, and just compared them, these 2 individuals with type 2 and the controls, and we found the insulin release was much lower. And therefore we said maybe this is a diagenic, and that's what we published early on. And now we have actually 4 cases with NeuroD1 PDX1, and we screened more than 1,000 controls, and we don't find this combination in the controls. And so in 2014, there came a database called Diagenic Disease Database. There were 54 diseases included. Three cases were included in this Diagenic Disease Database. Out of these 3 cases, 2 cases from our lab. And now it's been changed into Oligogenic Disease Database, where there are 7 combinations under MODY, and we have actually 14 combinations in our lab which we are investigating. So what we find is basically many of such variants may be predisposing factor or likely predisposing factors, because we also have a variant in NeuroD1 gene. When you see this variant in obese individuals, you see them becoming young diabetic. So meaning they need additional environmental factors. Or in NeuroD1 PDX1, they need additional genetic factors. So these are all, now the ACMG is now expanding their classification itself, where they're saying predisposing and likely predisposing. And I think we think that such variants actually are there, which need to be investigated further. And we've been utilizing this predisposing, likely predisposing even before ACMG has recommended. So with the little time that we have, we've also actually developed another arm where I said initially I showed you the lipodystrophy and insulin resistance, and we have a 6-gene panel, and we have screened quite a numbers. Now this is the largest series published in scientific reports. I'm not going to just get into the data, but just show you that we are just kind of covering up as much as possible in diabetes diagnosis, genetic forms of diabetes, right? So now we also have established an assay for mitochondrial mutation, identifying mitochondrial mutation. In mitochondria, you know of heteroplasmy, meaning not every mitochondria have the mutation. So if the percentage of mitochondria, if it's above 30-40%, you can pick it up with the Sanger itself. But if it goes down below 10-15, it is very difficult. But we've been able to even pick up less than 5%. Now we have technology which can actually pick up even 1%. So we have established, we sequence the whole mitochondrial genome, pick up even these heteroplasmies with high sensitivity. So what do we recommend? We recommend those where you rule out type 1 and type 2, you can either go in based on the clinical picture, you are into MODY workup or a lipodystrophy insulin resistance workup. And those negative, we also know that those negative may be MODY-X. the genes yet to be found. Now we screen up to 62 genes in our lab now, and also we have got a PacBio system which is like the top end in accuracy. We've been working with Q20 data, that is 99% data till now. Now we're getting a Q40, Q50 data, meaning it is 1 in 10,000 to 1 in 100,000 errors. So it's like highly sensitive system, highly accurate system in the lab. Now we're going to investigate more of MODX and go beyond and see what we have in those negatives. So we have up to 62 genes now. And also another arm that we are working on is hyperinsulinism. So we have ICMR funded project where we have been able to develop a 30 gene panel, and also we have an in-house 10 gene panel, and we actually work this up for the 30 gene panel with the fastest turnaround times. And another arm that we are working in endocrinology is on congenital adrenal hyperplasia, where when everybody were doing Sanger, we did NGS. But when everybody jumped on and said, okay, we're going to do NGS, in case like CH, we said NGS is not the solution. Because the CYP21A2 gene actually has a homology, a 98% homology with the pseudogene, right? So it is even difficult to amplify. In this case, we said, no, just genotyping is the method. And what we've done, my student Lavanya just finished her PhD, actually developed allele-specific PCRs, which actually can accurately identify all the 8 hotspots, and 85% actually can be picked up. Classical CH cases just can be picked up just by PCR-based methods. And we found even some of the chimeras can be picked up by just looking at the number of mutations positive. And those negative alone needs the NGS-based method. So we are also working on long-read sequencing and further workup. So we have, this is again ICMR-funded project which we are working. So I have a very hard-working team. This is all not possible without a hard-working and passionate team. So I have a very hard-working team. And more importantly, I also have Dr. Nihal, who is a strong person who actually supports our efforts quite a bit. And so it's an effort, like, you know, it's a clinician and a scientist who work together. And as I said, we are proud to say that in CMC we have worked together and come this far. And we are at a junction where we are moving forward. I'll just show you next slide. But I want to thank all the departments with whom we work. And we are well funded with various Indian funding agencies. And we all started with a single room there. Can you see the red circle there? We started in that single room. And now we have got a full floor of 3,000 square foot floor we've got, and this is a team. And I thank my team as well, who's put in their best efforts, and thank you all for patiently listening.
Thank you, Dr. Aaron, for that fascinating presentation. I think we can take 2 questions at this stage. Please, Dr. Mathur. I think, sir, you should use the mic there. Or Now I have the pleasure of introducing an out-of-box thinker, I must say, sir. So, so talking about Sandeep Mathur, sir, he is a clinician and scientist amalgamated into one. So he has his own high-profile endocrine center looking at all complex problems, and he has done a lot of research, multiple intramural grants, ICMR, CSIR, RSSDI, and then the local diabetic research foundation. So while people were looking at all the big things, sir wanted to look at it from a different point of view. I think it's some fascinating research, involves a lot of bioinformatics, which I don't understand. I think you will throw light on that, sir.
Yeah.
Over to you.
Thank you very much. Actually, now we are moving from genetics to genomic medicine. Somebody asked, you are interested in genetics? I say, no, I am in genomic medicine. Thanks to this fellow team with the opportunity to speak on something, something unusual, that is low gene expression of lipodystrophy in type 2 diabetes mellitus. You know, the whole story I am going to tell you is unusual in the sense that Asian Indians have thin fat phenotype. I think Dr. Mohan is the inspiring person to think about all these things in this country. And we have a genetic, this is a common disease, we have a rare genetic disease, lipodystrophy syndrome. The story I am going to tell you is that one disease which is on the left side is a monogenic disorder with single mutation in particular gene that manifests as a detrimental clinical phenotype. I am coming with the concept, the concept is relatively actually new, and most of the things are from our lab only, that functional defects in those genes can present like mild disease type 2 diabetes, particularly our phenotype. Actually, yesterday there were a lot of discussion workshop, and we have a different disease, and we came to some consensus also that functional lipodystrophy syndrome and functional Modi syndrome could be the real problem in our country. We may not get classical Modi. There could be some defect in the expression of Modi genes in our beta cell that can present as lean thin person with beta cell failure and type 2 diabetes. On the other hand, we have a group of people who have functional defect in lipodystrophy gene, which now we have data to prove it, and that present as type 2 diabetes mellitus. So in context of overall spectrum type 2 I am trying to put one side, that is insulin resistant phenotype. What is lipodystrophy syndrome? No, a very simple answer. Congenital, I am shifting directly to the congenital lipodystrophy. I am not going to talk about acquired lipodystrophy and HIV and all that will complicate the issue. Congenital lipodystrophies are heterogeneous group of disorders characterized by varying degree of fat loss and predisposition to insulin resistance and related metabolic complications. Very simple. Phenotypically, lack of protective fat at one end and your metabolic complication and metabolic vascular complication at the other hand, but high severe degree in your case of classical lipodystrophy syndrome. And there are different patterns of subcutaneous fat loss. Some group, because there are different pedigrees, and they were picked up from your clinical practice, the patient who has some pattern of fat loss. There was, the problem was running in the families, linkage analysis was done on your gene mapping, and a syndrome was identified. So there are different patterns of fat loss, some with the upper limb loss, lower limb loss, and on imaging they all can be demonstrated. I will not go into detail of that, all those things. But clinical manifestation of lipodystrophy resemble insulin resistance and obesity. But in our scenario, it is obesity, is metabolic obesity, not a BMI diagnosed obesity. They lead to severe elevated triglyceride, severe insulin resistance in lipodystrophy syndrome, ectopic fat deposition, progression to poor controlled diabetes, and complication of diabetes. Very important, complication of diabetes is also very high in them. They are at risk of hypertension, hyperphagia, kidney problem, mood problem, pancreatitis, and of course PCOD-like problem. And this picture, which is severe one, mimics your type 2 diabetes mellitus in the particular person who are not obese, and majority of patients in our practice are of this category. Now, does the body fat compartmentalization in South Asian T2DM and METS individual mimics partial lipodystrophy syndrome? It is very important issue. Is T2DM or METS I am using word METS also all the time because I am more interested in all clustering disease rather than diabetes alone, is due to adipose tissue excess or relative deficiency in protective compartment. Because classically we said T2DM is a disease of obesity, but it is not scenario in majority of our people in our country, and at least good number of people in our country. And traditionally this metabolism Asian Indian is attributed to excess visceral fat. There is excellent documentation of this association, of course from Chennai and Dr. Mohan's group. And in the Asian Indians have excess interperitoneal fat than control. That's why we believe they are at high risk of all the problems. But you see, so much of data, world literature full of data, but single paper has motivated to rethink. You surgically remove the momentum, there is no effect. That means we talk of intraperitoneal fat and half of it is removed surgically, there is no impact. Otherwise, one could have developed a therapy by removal of the momentum 50 years ago and there could have been any diabetes. No, this is not the fact. So this is very, very interesting, and I think all thinking process changed with this particular study. So we looked for which intra-abdominal compartment is important. It is intraperitoneal fat around your vital organs. Is it your subcutaneous abdominal fat or it is your fat in the liver? What we find that intra-abdominal fat volume were little higher, but when corrected, log corrected HOMA and liver fat, we find that T2DM was associated with more liver fat. Secondly, HOMA-IR show stronger association with in diabetics as well as MET syndrome with liver fat. Liver fat show strong association, but your subcutaneous fat doesn't show any association, and your fat in the around the vital organ show a weak correlation in highest quartile. And most important point is that we always say insulin resistant compartment relationship. We actually looked at this issue in a different spectrum, different horizon, and we clustered the patient according to severity of insulin resistance. And interestingly, we find HOMA IR showed very strong correlation in your highest quartile with liver fat. As your insulin resistance quartile goes up, role of liver fat become stronger. And in the highest quartile, there was a negative trend with your subcutaneous fat. So this indicate your abdominal compartment fat volume, including liver, intraperitoneal vital organs and subcutaneous, depends on the severity of insulin resistance. In highest quartile, liver fat show very strong correlation, and subcutaneous there is a trend for negative correlation. So this is the fat redistribution, fat distribution, and its relationship depends on the severity of insulin resistance. And this is of course a cross-sectional data. So then I looked back on some of the studies published from India. They looked for abdominal central fat and peripheral fat. The study from Anup Mishra, which is well actually cited, what I can see, yes, definitely, as they have shown, the liver span was high, pancreatic volume was high, but they were not much high in subcutaneous tissue. But re-look at their data, when clinical data, thigh and calf skin fold thickness were thinner in diabetics as compared to non-diabetics. Attention was on this side. Of course, abdominal parameters of total truncal is all are high, but there was not much attention of less in the periphery. Similarly, you see, same thing is here also. The focus was not on the periphery, but it was less. I think I'm going back, yeah. Then I look at the supplementary material of same paper, and I find peripheral fat on DEXA was much less in diabetes as compared to non-diabetes, but nobody talked about that, and I think this was ignored. And similarly, we had one study, not a very good journal. We find pioglitazone induced reduction in insulin resistance correlated with the increase in the peripheral fat mass on DEXA. That means peripheral fat is very important for Asian Indians. And so high insulin resistance and T2D and metabolic risk in South Asian Indians is possibly due to excess ectopic fat deposition, relative deficiency of the mass of protective peripheral subcutaneous adipose compartment. Therefore, it resembles partial lipodystrophy syndrome. So here the story begins. Partial lipodystrophy syndrome, less fat in the periphery, more ectopic fat. This resembles your partial lipodystrophy syndrome, and Indian phenotype also resembles this. Thus, lipodystrophy and T2DM metabolic syndrome share a common pathophysiological mechanism. Yeah. The pathophysiology of congenital lipodystrophies are well deciphered. Why I am talking congenital lipodystrophy, bring them in the story of type 2 diabetes, particularly our population, is because they are genetic mutation, consequent cellular morphology, their molecular pathophysiology, their metabolic molecular physiology, vascular molecular, they are all well deciphered. There is no doubt about it. Can it help in understanding type 2 diabetes, pathophysiology, particularly in this type of Indian phenotype? So the pathophysiology of congenital lipodystrophy is well understood, and challenging question is, does T2D meds can also have similar adipocentric pathophysiology? Because T2DM, our country, we always talk diabetes disease of beta cell function. Actually, I will do some work on that area, beta cell story and adipose tissue. That will be something I will be doing in future. But I can say this is a very important pathophysiological mechanism in our phenotype. So does it share a common thread? Most of the lipodystrophy syndromes, they are converged on the pathway of either triglyceride synthesis, adipocyte development, and adipogenesis, or adipocyte storage of triglyceride. Very crystal clear. Gene is known, mutation is known, function is known, clinical phenotype is known. Unlike type 2, where we still have some dark areas, we don't know much about it. But their main problem is adipose tissue fat handling. This is very crystal clear. It would be adipogenesis failure. On the same line, and their pathophysiology is also very clear. Fat get deposited in non-protective compartment, go to ectopic compartment. Ectopic compartment can be in your pancreas, liver, muscle, everywhere. Lot many work of animal done from Schulman, and they have crystal clear shown that this is a mechanism of insulin resistance to all the organ. If you go to the Schulman paper in Cell in 1913, I think a very good paper, a landmark paper to shape your thinking. So what we did, on the same line, we were funded by ICMR on a project of clinical biochemical and cellular correlation of transcriptome of adipose tissue, Asian Indian diabetes. Everybody laughed at me, why you want to look for correlation study of transcriptome, there will be lot of noise, lot of confusion. Let me explore it, whatever it is. So we look for deep phenotyping, then we had adipose tissue biopsy during surgery. We did microarray at that time, though we started RNA-seq later on, but still the work is going on. And we find a correlation between transcription signatures and clinical phenotype. And all these papers are now published almost 7-8 years ago. And we have clearly shown that several modules of co-expressed gene in visceral subcutaneous femoral adipose reports show a significant correlation with various diabetes-related intermediate phenotypic traits. They enrich several pathogenic molecular pathways such as inflammation and adipogenesis. So lipodystrophy, cellular mechanism, cellular pathway where most genes are actually converging is adipogenesis. And in adipose tissue, our all compartment, let it be femoral compartment from patient undergoing surgery for femur bone, for trauma, and in your abdominal compartment, visceral subcutaneous, everywhere the story is same. All the molecular pathway which show correlation disease-related intermediate phenotypic traits, they converge on the process of adipogenesis failure and consequent inflammation. So story are coming merging. A story of your lipodystrophy and a story of your Indian phenotype, they are merging at least of molecular pathophysiology in adipose tissue level. And the emerging evidences on type 2 pathophysiology, again the same thing is coming up. Like a lipodystrophy where definitely nutrient overflow is the real mechanism, undisputed. And similar pattern is emerging in your all evidences are appearing for your type 2 diabetes mellitus. So molecular pathophysiology, adipose tissue and consequent metabolic dysfunction and vascular dysfunction, they are on the same lines at least. They are similar, not the same, on the same lines. No, inference is that at the level of transcriptome, T2D and MET syndrome is associated with impaired adipogenesis in adipose tissue. Hence, it shares a common molecular pathophysiology with lipodystrophy syndrome. Therefore, well-deciphered pathophysiology mechanism can serve as a template to study pathophysiology T2D and metabolic syndrome population. Because here, everything in lipodystrophy, even monogenic disorder, everything comes out of adipose tissue only. Type 2, we tolerate this organ dysfunction, that organ dysfunction. Now question is, very challenging question for me, is beta cell function is simply because of your adipose tissue dysfunction, and whatever gene, they are modulators, they are not the major drivers of the pathophysiology. Similar for brain changes, liver changes, muscle changes. Animal experimental data also suggests this type of evidence. The primary defect could possibly in type 2 diabetes, which we see particularly lean metabolic syndrome patients, could be because primarily driven by adipose tissue dysfunction. Does T2D and lipodystrophy share a common genetic susceptibility? A very important issue, because as a molecular investigator, I looked at every disease genome to phenome pathway and trajectories. Because if we shed light on all its aspects, we have a crystal clear picture of the disease. With that in mind, first thing let me look for, does they share common genetic susceptibility? Because everybody is screened for lipodystrophy gene and they find they are negative. I think Nihal has presented many times this point. But that doesn't mean it is 100% negative. Congenital lipodystrophies are monogenic disorder. I already mentioned that. Mutation in single gene is the basis of their multifaceted pathophysiology, and they are well deciphered in several pedigrees. Because their genetic mutation identified in the pedigrees. T2 in a metabolic syndrome of complex multifactorial disease, and their underlying genetic variants are not only partly understood. Now I'm telling you some basic concept of genetics and genomic medicine. What are the things? Any genetic variant, there are 0.01% or 0.005% variant in human genome. If a genetic polymorph is rare, it has a big impact on your pathophysiology. It leads to monogenic disease. On the other hand, If that polymorph is not so rare, it is relatively common, not very common, relatively common, has some impact on your pathophysiology. So one end it will lead to monogenic disorder, and other end it will lead to polygenic disorder. So T2DM phenotypically resembles lipodystrophy syndrome. So my model of disease, if there are genetic variants in large number of genes and they are contributing to manifest clinically as a disease, as a complex trait, and they conspire with environmental factor also. But monogenic environmental factor role is limited. So with this frame or reference of thinking genetic and genomics, I'm going to the next point. I've already mentioned all the genes which are known to cause lipodystrophy syndrome, and they are actually pathophysiology at lipid handling by your adipocyte is well deciphered, undisputed, and this is the story. I will not take more of your time in talking about each one individually, but in summary, they are actually mainly related to adipogenesis, adipose tissue, lipid droplet formation, its function, and lipid synthesis in the adipocyte. So now coming to conceptual model of complex genetic disease and multiomics. I already mentioned for complex disease like T2D metabolic syndrome, one component or factor in disease causation is genetic susceptibility. Already mentioned several genetic polymorphs with milder phenotypic impact. There might be unknown changes, there might be epigenomic changes, there might be social, host or environmental factor, all lead to disease. Now how to investigate them? I think one of the things which has happened in last 20 years after Human Genome Project is multi-omics strategies. Means you look at the genome, you look at the transcriptome, you look at the proteome and metabolome all together with clinical phenotype at one end, try to figure out what is the possible mechanism. So first step in deciphering genome to phenome pathway in complex genetic trait is basically genome-wide association history. Genetic markers are present throughout the genome and their typing is done and it is correlated with the clinical phenotype like occurrence of diabetes or its intermediate phenotypic trait, and an impression is made that these genetic loci possibly has some association with diabetes mellitus like this. So now we have actually meta-analysis of jivas, because last 15 years so many jivas are done. We also did jiva for diabetes in India. All meta-analysis done. It is said if the sample size exceed 1 lakh, there is no advantage of having more sample size, and crystal clear there are subclusters of genetic risk score actually. This genetic risk score based on clinical phenotype of patient as well as genetic variant, there are subclusters. And these clusters, when you were examined for Asian Indian population, it is very interestingly find it is a beta cell 2 insulin deficiency, lipodystrophy 1, unfavorable fat distribution. These clinical phenotypes are clustering with genetic susceptibility. If you say occurrence of T2DM in Indian population, how the gene manifests into a disease, at least two broad actually mechanism, either impairment in beta cell function or it is fat redistribution. And obesity cluster which was found in West Caucasian population was not seen in our population. So at genome level also, occurrence of diabetes in South Asian is not related to obesity, it is rather related to fat distribution, which is again even officially labeled as lipodystrophy. So I can go to next slide. Now question is T2DM metaphenotype associated with altered expression lipodystrophy gene in adipose tissue. Now I'm shifting from gene structure, gene sequence polymorphs to gene function aspect of the pathophysiology, because functional genomics really gives you right answer to most of your question. Does T2DM and metaphenotype syndrome share a common molecular pathway and mechanism with lipodystrophy syndrome and portray functional defects in genes predisposing to congenital lipodystrophy, a monogenic genetic disorder due to germline mutation? So our hypothesis is that a gene, if it is mutated, severe effect will lead to type lipodystrophy syndrome. If the expression of that gene is altered unfavorably in your adipose tissue, it will lead to a milder variety of disease. So this is our basic hypothesis on which we are building the whole story. You see, first paper we published was a hypothesis generating paper. We looked for these most lipodystrophy syndrome genes. They converge on adipocyte life cycle, mesenchymal cell, its recruitment, its proliferation, differentiation, and their apoptosis. So they converge on this process of adipogenesis. We looked in the gene mania, which is a plug-in on cytoscope bioinformatic analysis tool, and see, and this gives you information. You put some list of genes, this give the information what are the networks on which the gene is working, because no gene work in isolation. If you know about any gene and see what it is causing for monogenic disorder, they may be having little impact of your other gene interaction, but polygenic disease interaction with other gene is equally important. So gene network analysis is a very important part of genomic studies, and we find, and they also give information what are the cellular molecular function of the gene. So gene mania, we find most of the lipodystrophy gene, they were annotated to adipose tissue function and T2DM metabolism pathophysiologic pathway. So this is in beginning of the point. Then we developed a network of lipodystrophy genes. And when we subjected all lipodystrophy genes to a network, it provided clue about pathways and genetic determinants of diabetes mellitus and subtypes based on unique lipodystrophy related pathway. I want to repeat what I am saying here. Their adipose tissue is there. There must be some patient where one lipodystrophy gene mutation functional defect could have a major dominant effect in the pathophysiology of adipose tissue. This is what hypothesis we generated in this paper. And we look for expression of lipodystrophy gene, our database of transcription profile of adipose tissue, and 4 of the genes were differentially expressed in T2DM patient as compared to non-diabetics. Therefore, this finding suggests that T2DM metabolic syndrome could be due to functional defects in lipodystrophy syndrome susceptibility gene. This was the beginning of the story, because initially only 4 genes were there. Subsequently, we did another investigation. We looked over transcriptome databases for lipodystrophy genes. What we find, there were 2,537 genes show differential expression in diabetics in the peripheral compartment I am talking of, because I am talking lipodystrophy syndrome. And 16 out of 138 lipodystrophy genes were differentially regulated in diabetics. That means 16 genes which are known to cause lipodystrophy were showing altered expression. They were part of large number of genes. And when we developed a network of diabetes genes, differentially expressed gene, and network of lipodystrophy gene. I already mentioned, when we talk about gene as a function, we should always talk in terms of gene network, because no gene work in isolation. There was 18% overlap between the network of lipodystrophy gene and D gene peripheral compartment. So there is a 20% resemblance between these two lipodystrophy genes, functional defects, and your type 2 diabetes mellitus. The expression level lipodystrophy gene also showed an association with disease-related intermediate phenotypic. It is not just an association, it shows an intermediate phenotypic trait also. Another important thing which came out of this analysis was that 25 out of 30 diabetic individuals where we had adipose tissue biopsy and look for transcription profiling, 25 individuals show at least plus minus 2-fold up and down regulation expression of lipodystrophy gene in peripheral adipose tissue. It is very important. If we individualize, we should say 1 patient, 2 patient, 3 patient, 5 patient. So we had 30 patients. 25 patients, there was altered expression, one of these lipodystrophy gene, 2-fold, either up or down. And we could individualize the patient on the basis of expression of these genes. So if we talk today, we talk every diabetes is unique. The uniqueness will come where ultimately we will do subcluster cluster classification. So this is the beginning of area of adipose tissue expression of lipodystrophy gene or some of the gene. Gene expression culture can be the ultimate subclustering of T2 diabetes, because adipose tissue pathology, in my opinion, major player in pathophysiology, our therapeutic strategies should have at least some emphasis on this adipose tissue, and in future, so we are doing some other work, but there will be therapeutic strategy and subclustering according to this gene expression pattern of lipodystrophy-like genes. Now coming to the last part of my presentation, I hope I will finish on time. We actually look for expression of lipodystrophy gene in another cohort. Previous study were looking for lipodystrophy in whole genome, whole transcriptome profiles. Now we're looking for individual genes, 50 gene panel in adipose tissue compartment, how it correlates with clinical phenotypes. So this was actually RSCDI and MMRS funded project. So objective were to decipher the probable link between selected set of 50 lipodystrophy genes with T2D metabolic syndrome pathophysiology by measuring their expression in abdominal femoral adipose tissue using qPCR, because qPCR is the ultimate method, because in micro there is a lot of noise and it is a limitation. And to classify individual clinical severity of clinical metabolic syndrome based on lipodystrophy gene expression using machine learning technique, decision tree to personalize patient care. I tried to predict severity of metabolic syndrome on the basis of combination of expression using machine model to the severity of metabolic syndrome. Some patients did not have metabolic syndrome, they were the controller, some has severe metabolic syndrome. So number of component metabolic syndrome we look for on the basis of expression of these 50 genes. We find there was a network of lipodystrophy gene, and gene network we also created T2D interactome and 132 plated T2D effector genes, which are known to have an impact on transcription profile, T2D supply gene impact on the gene expression, and the network of lipodystrophy genes, and there was a 51% overlap. Out of 238 non-lipodystrophy gene, we use some bioinformatic tool, Aditya has done it, he said there is a most probable likely. On the basis of expression, there is 51 gene, their network of expression and gene loci known to cause type 2 diabetes mellitus and their effector gene network, we look for there was 51% overlap. That means the whole complex issue of 23,000 gene narrowed down to 50 gene when you come to type 2 diabetes mellitus. So this is a window open for looking very specifically a specific subpattern in adipose tissue, and they all emerge on the pathway of insulin signaling, adipogenesis, and leptin signaling, and AGE, RAG signaling pathway. So pathways identified were all the same, which were known to cause T2DM. Most important finding was most of the lipodystrophy genes which are protective against this metabolism were downregulated, and those genes which were causing metabolic syndrome, they were upregulated in diabetes. A very inconsistent finding. That means type 2 diabetes mellitus, which we see in our practice, what it could be type 2, type 4, type 5 or whatever it is, because yesterday we were discussing type 5. I am very much interested in this type 5 because we are a different phenotype. And they all were showing altered expression. It is right. What is the cause? That is a second story. But at least functional lipodystrophy exists in our T2DM patients. Number two, not only this, their expression correlates with your intermediate phenotypic traits also. So these are the traits and their associated genes. And lastly and more important, my previous transcription profiling genome, whole genome, actually genome-wide transcription profiling, what I find, there were modules of co-expressed gene and their number was not more than 12, 13. You see 20,000 gene expression, their signature, their variation, all these things. You can imagine millions of billions of computational combination. But there was a train to only 8 to 12 modules of co-expressed gene. That means, suppose there are 50 people, 500 people sitting here, but we can cluster 5 are from here, 5 from here, 5 from here, only 5 or 6 cluster. So this modulo co-expressed gene story, our lipodystrophy genes converge on some of them. So this gives the impression that if one gene is mutated, it will lead to classical lipodystrophy syndrome. If it is functionally altered, they are clustered only in few clusters and their functional alteration lead to your class type 2 diabetes mellitus. Now most important part of this paper, and fortunately Dr. Mohan and Radha also one of our co-author in this paper, and thanks to Dr. Mohan to paying my attention to some very important paper for Sarah Feiner and that group, because that correlates with our, actually they did Jivas and came to same conclusion, we did gene function study, came to the same conclusion, that a decision tree classifier 50 lipid genes was built. It could segregate all 117 samples into 50 subgroups belonging to metabolic syndrome score 0 to 5. That means 50 gene expression in adipose tissue, On the basis of their expression pattern, we use machine learning model. Can we predict the severity of metabolic syndrome in terms of existence 1, 2, 3, 4, 5 of cluster diseases? It's a number of cluster disease. Our decision tree could segregate 1 to 2 patients along a particular path from root node to METS class level. That means, suppose one gene expression, 2 gene, second gene, third gene, the combination, permutation combination, and there were only 112 permutation combination, and we can only 50 permutation combination, and we can classify all the patient according to subcluster according to them. This observation that 2 patients per path, 117 patients, 50 paths. So permutation combination, there were only 50 paths. We are lucky to find this type of thing. And on this 50 path, our all patients were fitted into it. Some 2 are in this part, 2 are in this part, and we can predict severity of metabolic syndrome. Other way around, severity of metabolic syndrome in an individual or occurrence of metabolic syndrome or dysmetabolism, it can be explained on the basis of expression just 50 lipodystrophy genes. That means so complex trait, everybody is very complex, is narrowed down functionally to only 50 gene permutation combination expression in adipose tissue. And from this analysis, we were able to conclude that expression of just 20, and out of this, more important, only 28 genes in 50. These genes, out of 150 genes, is sufficient to classify all patients. Interestingly, the first 10 genes were also present in lipodystrophy panel. So 28 genes, even 22 genes we used in our analysis, they were of not much value. 28 gene expression, you can predict. This is in subcutaneous compartment because we can easily biopsy subcutaneous adipose tissue. You can predict metabolic syndrome, and we can subcluster them into 50 groups. So the finding that genomic network of lipodystrophy gene showing overlap with the differentially expressed gene in peripheral adipose tissue suggests that T2DM could be a functional lipodystrophy syndrome. This is the bottom line conclusion from these studies. So the conclusion that thin fat Asian Indians and lipodystrophy syndrome not only share common patterns of adipose tissue compartmentalization, pathophysiology, clinical manifestation, but they also share overlapping genetic predisposition and functional genomic mechanism at gene expression in adipose tissue. This concept of cluster of functional lipodystrophy syndrome of insulin resistant state has opened the avenues for the molecular subclustering according to unimolecular pathophysiology of lipodystrophy syndrome and future development pathophysiology specific personalized therapy. And thank you very much for the patience hearing.
Me to speak in this august audience and as well as in this forum, and special thanks to Dr. Nehal Thomas and also Dr. Aaron Chapla. So I'm today going to talk about the functional studies in monogenic diabetes that we're doing in MDRF. So I'm just going to give you a quick introduction of monogenic disease, which we've been discussing, Aaron has been discussing, and almost everybody has been discussing about. But I want to put this, what I'm going to talk is about the experimental process, but I want to put this in the context of monogenic in general. And particularly, I want to tell you what, I want you to understand what we are doing and why we are doing what we are doing and how we are doing what we are doing. So that is exactly going to be my talk today. So I'm just going to present only a very, a few of them. And if you want any more clarification on them, you're most welcome to discuss it in person. So I would like to very much acknowledge the Indian Council of Medical Research for their financial support, and Dr. Mohan and Dr. Anjana for being with me, ahead of me, behind me, and everything. I always tell Dr. Mohan that. And all the clinical collaborators who have given me the samples, particularly Dr. Vandana Jain, who's here from All India Institute of Medical Sciences, and the patients and their family members, and finally my lovely team, who's always with me in all the work that we are doing. We are completely thinking about the molecular genetics, the functional aspects of it. I mean, a lot of monogenic diabetes and some type 2 diabetes as well, and it's going to be a complete genetics laboratory. Right. So to come to the definition quickly of the monogenic diabetes, as you know, that's by the single gene defect. which strongly contributes to the disease phenotype, and without environmental contribution much, and also it has very high penetrance and complete penetrance. And the type, as you know, is one is the MODY, maturity onset diabetes in the young, the other is the neonatal diabetes, and then the syndromes of diabetes. Monogenic diabetes, as you know, is only the beta cell diabetes, and it is, as you know, that the pancreatic beta cell is very fundamental in maintaining the glucose levels, and which has to match insulin secretion to ambient glucose. And this is actually, the glucose is sensed via multiple steps, and any problem there, to result in ATP generation, and any problem in that pathway, any mutation there, that is what causes the single gene defect or the monogenic diabetes form. And there you do see a wide range of protein dysfunction, which results not only in monogenic diabetes, but the exact opposite phenotype, which is the congenital hyperinsulinism or CHI. We are working on that as well in a very deep level, but of course that is not going to be presented today. Today I am going to only concentrate on MODY and neonatal diabetes. So the basic fundamental is that the rare loss of function mutation in 1-alpha, 1,4-alpha, HNF1 beta and PDX, some of these genes cause highly penetrant Mendelian disorder, the rare loss of function, and that is the maturity onset diabetes. And rare gain of function mutations also we see, that causes neonatal diabetes, and the rare gain of function mutation actually happens in ABCC10 and KCNJ11 genes, and the rare loss of function mutation here causes hyperinsulinism. So you do see totally different scenario here, gain of function and loss of function. So it is this that really forms the fundamental basis. So if you look at the whole population and look at the Jain variants itself and their impact, as we were discussing, so there is a frequency in population, and gradually from polymorphism, and some of the polymorphisms obviously are not associated at all with disease. Some of them are associated as something like a signpost, and some of them are possibly associated in a milder form with the diabetes. And then you have this mutation or the sudden change in a gene which impacts. So that could be disease, not disease causing, and finally certainly disease causing. So this is the spectrum that we are looking at, and I'm going to concentrate on just the mutation here, the disease causing and probably, and possibly and the probably disease causing ones. Right. So the fundamental genetic basis of MODY is that there is this component of insulin secretory pathway, that is the ABCC10 and KCNJ11 included in MODY, and also the developmentally important transcription factor pathways. And they play a very crucial role in the metabolism of glucose, in their regulation of insulin or other genes involved. So the other genes are actually, that is what the transcription factor genes really do. They have the target genes, and then they work through the target genes to impair the glucose metabolism. So if you go to the genetic basis of neonatal diabetes, again, you do have a number of genes here, about 30 genes or so, but not all of them are very frequent in their appearance. You do see prominence only with the ATP channel genes, so which is very important. That is where the glucose sensing takes place. That is the crux of the genes, where, through the multiple, that is the one, the ATP, which triggers this channel. That only depolarizes this beta cell and then secretes the insulin, the synthesized insulin. So this gives a trigger for the channel closure and the triggering of insulin secretion. So as I said, that the activating mutation in this gene, they prevent the channel closure, and hence also the insulin secretion is prevented in response to hyperglycemia, and that leads to NDM. And these patients, actually they have insulin, they are being treated with insulin. They really don't require it. So that is what we are going to study here. And then the functional defect in the pore closing of the channel, that can be rectified by administering appropriate drugs. And one of them is sulfonylurea, because the whole problem happens in ABCC81 gene, which produces sulfonylurea protein. So with this detection, a quick how do we sort of bucket all these syndromes is that HNF1 alpha, 1 beta, GCK, etc. They are in the maturity onset diabetes in the young, and the KCN, J11, ABCC8, GCK, NKX 2.2, of which we are working a lot. That actually can be a lot of NDMs really to have it. And then you have this syndrome such as WFS Wolframin and TRMA syndrome, and then, Volkert-Rallison syndrome, etc. And again, you have what is known as the congenital hyperinsulinism, which is exactly the opposite. But then again, the same genes are also, most of the genes that are involved in NDM are involved obviously in CHA as well. So, what is very important in this case is, each of these genes is etiological. So when we are talking about this, we are automatically talking only about the etiological groups. Say for example, ABCC8 MODY, HNF1 alpha MODY. So it is like that. So ABCC8 NDM and ABCC8 CHI. So that is how it has to be looked into. So the cardinal questions that we started asking ourselves now are, can we detect the gene variants? Yes, we can, because we do have so many machines now doing it. And can genetic information be used to understand the cause of monogenic diabetes? Yes, they can be. And can we tailor treatment to the cause? Yes, we can in most of the cases. And can genetic information be used for translation from bench to bedside? Yes, in most of the cases. And are these variants clinically actionable? Yes, again, in most of them are. So we can now tailor treatment to suit the gene variants, and the outcome is actually heavily determined not just by the gene, but by the variants in the gene. The gene is formed of variants, and can any polymorphism be called? Can anything be called a mutation? No, it cannot be. Even if it is in a very minor proportion, even if it is present, and identified in a, in a diseased person, even then, you cannot say whether that is the cause, because you really have to prove it. That is what is a very tough thing, and that's what we are doing now. So all these questions are now being asked and now being presented. And this was possible because we could assess the variant pathogenicity. So assessing the variant pathogenicity, when you come, not all variants are pathogenic and not all variants are clinically actionable. And evaluation of pathogenicity for the variants are very important, and that is what really determines whether it is MODY or not, or NDM or not, whether, how we can classify them into various types. And then to confirm this pathogenicity, so what we do is, there are a number of steps that we do. Say for example, bioinformatics, first of all the genetic identification, then the segregation within the family, and then the bioinformatic tools, the presence in databases such as the ClinVar, Nomad, Exact, etc. And do the burden testing, and also look for calculate the penetrance testing, etc. And applying the ACMG AMP guidelines. I'm also a part of the ClinVar and we apply all of them, but then there are a lot of changes that takes place. But most importantly, functional validation of their nature is very important. So when we are doing the functional validation, obviously in vivo function variation is not going to be possible, and therefore what we do is ex vivo, we take cell-based assays is one, another is the animal model. Many of the times animal model might not be very correlating with the disease status itself, and therefore we have chosen, as of now we have chosen only the cell-based assays. So what has really happened after doing all this is, even if ACMG gives the 5 classification as pathogenic, likely pathogenic, VUS, that is variant of uncertain significance, likely benign and benign, we still make use of our validation pipeline, that is the functional validation pipeline, and then reinterpret them. That's what I'm going to show you now. So this is just the basic information and clinical information that's required for the pathogenicity. Using the whole gamut of experimental and analytical approaches, that is the genetic, bioinformatics, structural biology is one thing that we do not do in our lab, but then I collaborate with the Indian Institute of Sciences to do that. And then evaluation and interpretation, that is very important. Evaluation and interpretation of variant pathogenicity, in vitro functional validation, and reinterpreting them, and then translating it to patients and following it up. That shows whether the proof is in the pudding. So that is what really happens. So we are doing all these things. So I can probably skip this in the interest of time. I will skip the case study, but then this particular patient came to us, was assessed elsewhere as type 1. But then when we took the family history, we could clearly see that a number of, family members, particularly on the maternal side, one of the sides really had diabetes at a young age, less than 32, 35, etc. And a novel, at that time it was a novel mutation, arginine 263 histidine in HNF1 alpha. And actually, at that time, Ewan Pearson had done very elegant experiments and proving how the loss of function missense variant predict response to sulfonylurea. And we did do the take her off from insulin, and we gave her sulfonylurea. Even now, she continues to have very good response, and she is off insulin completely. So you can see how Modi genetic testing has helped, and this is very clearly a translational medicine. And this is very clearly got to do with the variant. How is it got to do with the variant? We didn't stop there. We continued to do the experimental analysis. In fact, we continued with the progression. We have a lot of trajectories like this. Again, in the interest of time, I'm going to show you only one trajectory here. The fasting blood for number of mutations along with the trajectories. And for 5 years, and single patient with KCNJ11, this also is a Modi mutation, to showing trajectories for 4 years. So, we do see some clinical actionability in the case of the Modi, particularly HNF1, HNF4, ABCC8, KCNJ11, where in most of the cases we could shift them. Around 78% could be shifted to sulfonylurea, and some of HNF1 beta and insulin we could not do, and GCK of course does not require much of treatment except for diet. So change in the treatment profile actually in our case was that 17% were clear Modi after doing all the analysis, and 3 was not Modi, and 13 was uncertain, and 67 needs to be further classified novel genes we have to look into. So which means we have to go for whole genome sequencing rather than even exome sequencing, because genes could be anywhere, and none of us know where it is. None of us even know how many genes are there. Although we keep talking about 30,000, 20,000, or 25,000, we still do not know that. So again, coming to the clinical actionability, KCNJ11 again had this gain of function missense variant, predict response to high dose sulfonylurea. Again, that was shown by Ewan Pearson. It can also be seen in our case where very nice, lovely trajectories in KCNJ11 mutation for the 5 years. You can see the graph as well as the mutants. How it has happened. It continues to be, and there has not been a single failure in NDM after shifting to sulfonylurea based on genetic analysis. That I can vouch for from what we have done. This is the ABCCH gene. Okay, so this is just a quick trajectory. And I also want to show that there are 5 different NDM patients with the common arginine 201 cystine mutation. All of them have a common response, similar response, clearly showing that there is a correlation between the two. Now, so again, if you look at, when we looked at 135 patients, about 73% of them were successfully shifted. And some of them obviously could not be shifted. We do not know. Maybe we have to look for even different drugs. As of now, they are on insulin. We have to look at various other drugs. And some of them continue to be, and we have to look at various other genes as well. But what I want to now stress is the role of functional studies in understanding the clinical actionability, and also this delivers to precision medicine. So why is functional study important? This can help in monogenic diabetes. One is to determining treatment, optimizing treatment, predicting clinical course, managing familial risks, and also defining gene-related therapies. So monogenic diabetes can really provide unique models for studying the functional biology of pancreatic beta cells. So the functional experimental pipeline that we do in our lab in MDRFS, first we create the mutants by a single side-directed mutagenesis, and then we go for the characterization for transcription factor genes, coding for transcription factor proteins. One is assessing transcription activity, another is protein expression, then DNA binding assay, and to assess the localization of protein, and finally to look at the glucose-stimulated insulin secretion levels. Okay, these are the ones that we do. And then for characterizing the channel genes, which are very tough, the ABCC, particularly ABCC, is very big. So it is a very tough gene. It is not giving answers that easily, but we are fighting with it. So ABCC 10, KCNJ 11. So that has to be looked at differently. We have to assess the protein expression. We can't be doing a transcription factor analysis there because it's not a transcription factor analysis, it's a straightforward channel gene. So to assess, we have to assess protein expression. We use Western blot. We do trafficking studies using the surface expression. We also do the efflux assay, which helps in understanding whether what sort of pharmacological agent can really be given. The electrophysiological expression is one that we do not have because we do not have the electrophysiological subtype, which is very huge and extensive. But of course, we are collaborating with the experts throughout the world. And the next is the characterization of structural genes, which code for enzymes, say like the glucokinase, hexokinase, and also insulin genes. So we use Western blot, we use kinetic assays and activity assays. So the functional, initially we look at the functional domain. For example, if in the case of transcription factor, these two genes, we have what is known as dimerization protein, DNA binding, and transactivation motifs. But the very important thing here is that the type and the position of the variants really matter. Where is the variant present? Is it in this domain or is it in the transactivation domain? Or that is very important. And also the type of mutation that happens. That is very important. So that is why I said not all variants are mutants. Only some are. That has to be assessed, and that can only be assessed by functional assays. So for delivering, as I said about that HNF1 alpha mutation, the novel one that we discovered, that R263H pathogenic variant. I just want to give you how we have combined all the various informatic and structural biology multi-pronged approach that we have done. We have taken the segregation analysis and we have done structural analysis, we have done the functional analysis, and of course, this is our informatics where we have gone through the ACMG guidelines, and eventually we've also gone through them continuously and followed them up. So this gives you a complete picture of what's really happening with each variant. This is what I'm doing for all the variants. So which is a very, it's a very time consuming job. So, but that's what we are at, and we are very happy to do that. So now that has led us to reinterpret some of these HNF1 alpha variants. Okay, so initially, when we used all the informatics and ACMG guidelines, you can see that some of these variants were VUS, and LP is likely pathogenic. So after putting our functional assays and after putting in following the clinical workup, because already the clinical workup is taking place, okay, then we found we were able to reinterpret some of them. It required reinterpretation. Not everything requires reinterpretation, but here it required reinterpretation. So some of the VUSs have been shifted to LPs, and I think many of them, and one was also pathogenic, and there was one likely pathogenic which became pathogenic, that we could find out after doing the functional assay and follow up. So that is a very important aspect that I would like to stress, why functional assays are very important. Similarly, for the transactivation domain, the same thing happened. We did the classification initially, then we did so according to that classification, they are already being treated, and then we went back to them once we had set up all this, and then we did the functional assays, we did the clinical workup, and then we were able to reinterpret them. So again, you can see the difference between this. So what we did was we created lookup table. This is our main goal. We want to create lookup table for as many genes as we can, whichever is impacting the monogenic diabetes and CHI. So we have created a lookup table. So anywhere, if somebody suddenly finds some mutation, even after 10 years, they could certainly look this up and say, okay, this is pathogenic, because I can tell you clearly that if you find a novel gene or if you find a gene that's not been molecularly characterized, to go through it, to do the functional analysis is very difficult and very time consuming. So if you have already done it, so that really helps. And that was the purpose in which we started doing. And this exactly, again, with the, I would like to borrow about a couple of minutes, I'm sorry. So, and schematic representation, this is the ABCC81. We have done channel expression, and we have also found out the channel activity. and we were able to see some of the mutant channels in KATP with the inhibitors. So we were able to find out, characterize some of the around 5 mutations here. ABC site, as I said, is going slow because it's very tough. Because initially we have to create all mutants, that itself takes time. So the entire, spectrum of KATP that we have seen in our patients is from gain of function to loss of function. This is the way that we map every gene and the entire function. So, I'm sorry, I think so there is one question that has really been bothering us. What if we could test in advance the function of every possible amino acid substitution in HNF1 alpha and KATP, for example? Because I'm telling because these are very important genes in monogenic diabetes. So that was the question. That is where the validation really comes in. Why are you doing this functional assay? You're going to help. And when are you going to help? After some 10 years? No. I would like to help in advance. I would like to create lookup tables. I would like to have done it. And that is the reason why this question was asked. And how do you know what mutation is going to come up? I'm not going to know. I'm not. So create everything. Do everything. So what if we do every possible amino acid? What would be the result? So this is what we did with one of our mutations in HNF1 alpha, the R263, and 20 possible mutants are being created. And we have done some of them, and we have also, particularly 1 or 2 of them, 4 of them have been created well under immediate possibility. And we have also done the transactivation functional analysis for all of them. And we have interpreted, and we have made some small lookup table for them as well. So to summarize, we have about, I think about 35 of them where we have done, excuse me. Even here, the 23, prospectively created ones have been, have also been reinterpreted here, and then we are able to give the analysis. So what happens is, on the one hand, we are getting the naturally occurring mutations, and on the other hand, we are prospectively creating and then doing the functional analysis. That is the functional status in molecular genetics of our laboratory in MDRF. So the take-home message here is it's very crucial to collect all important clinical features, and of course an obsessive attention to interpretation of variants is very important, and then reclassification of the disease subtypes using the functional basis is absolutely imperative. And genetic diagnosis actually will not only inform the likely course of treatment for monogenic, but also will predict the development of additional clinical features. It will also help as far as additional byproduct in the case of insights into novel insights into beta cell function. That certainly may inspire new lines of research for the therapy of diabetes, for development of therapy of diabetes, and as well as also congenital hyperinsulinism. So my own submission is that molecular genetics has certainly revolutionized diabetes clinic, and then the change is truly transformative. Thank you for your attention.
Thank you very much, madam. It was a great lecture. So it clearly showed us the importance of doing genetics, but also knowing that when we do genetics for a lot of patients, you're going to encounter VOS kind of presentation, and that's where majority of your functional studies would be definitely required, and to definitely set up a database to say that this gene is functionally going to be affecting. So what I took from as a clinician as an important message here is that definitely we are going to require this part, but we have to type our clinical phenotype very strongly, especially looking at the patient, going back to the families and trying to have familial segregations of a phenotypic features so as to make a genetic diagnosis stronger and help you out in looking out in functional activities. So thank you very much for that. Any questions, if somebody?
I think this is the complete story of genomic medicine, I will tell you. Without functional studies, clinical validation, identification and mutation is useless in my opinion. Because we are a different population. Our reference genome is also not very clear. You rightly said 67% of patients we were not able to find any non-Moody mutation. And next logical step is whole genome sequencing. I think I also believe in the same thing. My question is, can we look for defects in regulatory regions of these so-called beta cell function gene? do you think could it be right strategy for the regulatory regions? Because I have one hypothesis. Patients who have lean and thin, severe beta cell impairment, all antibodies negative, age is 65, 50, 60, they are very lean and thin, the advanced age, and they developed a severe type of diabetes, no evidence of insulin resistance or metabolic syndrome, nothing, and they respond very well to sulfonylurea. For that category, I believe, could there be, if like functional lipodystrophy syndrome for lipodystrophy for insulin resistance, could there be functional defects in genes regulating insulin secretion and play a role in this type of disease? That is something we can look for.
Right.
Yeah. So what is your opinion on that point?
Yeah, yes. So the 67%, all this percentage is because I'm only looking at a set of genes,
Yes.
right? It's only the set of genes. So the others, that is why I'm saying the others could be novel genes. That has not been implicated. So the best would be to go for whole genome sequencing. But to do whole genome sequencing and get all the interpretation done and get all the analysis done, it's not tomorrow's job. It's going to be really, it is very involving, but these days it is possible to do the technique. But to get all the database corrected and the interpretation, that is what we are working at. We have very distilled cohorts like that who are responding, but we are not able to find any genetic cause.
Okay,
So we have assembled, and we are going in for a novel gene discovery, and hopefully something will come, and look at various other mechanisms, what really happens. And if there is another gene, then we look at the pathway, whether that pathway gets affected, something novel comes up. For example, even NKX was a very recent one, not very recent, maybe recent one, and we were able to now find 2 of them. We are able to find a loss of stop loss, stop gain, and even that we have functionally characterized. So that is a way that I think.
Yeah, so I have one more.
Thank you, ma'am, for the
Thank you.
nice
Thank you
talk,
very
ma'am.
much.
And I request Shah sir to present the moment.
Talking on genetics of neonatal diabetes. So I'm a clinician. My talk will not be as hardcore genetics as the preceding 2 talks. So let's begin with the case. The 6 weeks old baby had very recently presented to us with the complaint of polyuria for 1 week, with lethargy and respiratory distress for 1 day. So when we looked into the history, the baby was a low birth weight, 2.2 kg. He was second born to a 3rd degree consanguineous couple, and they had traveled all the way from Bihar with this baby because previously they had the first offspring also who was diagnosed with persistent hyperglycemia at 1.5 months of age, and the baby had been admitted in another hospital for few weeks, but then they took the baby home, Lama, and the baby had expired. So no investigations had been done in that particular baby. So this baby is currently, his weight was low for age, but there was no dysmorphism. Systemic examination was normal. He had a very high random blood sugar. Ketosis was present, pH was 7.1, so a diagnosis of moderate DKA was made. He was treated appropriately. HbA1c was 8.4%. Ultrasound abdomen was normal, pancreas was visualized, LFT and thyroid function were normal. So now what is the diagnosis here, and how do we manage this baby? What is the prognosis? Parents have already lost 1 baby. This is a consanguineous couple, so what kind of inheritance pattern are we thinking of? These are the questions that we will try to answer as we move through the presentation. So neonatal diabetes, or probably more appropriate name would be monogenic diabetes of infancy, because it's not really neonatal presentation. Almost all cases of diabetes presenting before 6 months of age are monogenic in etiology, and a significant proportion of those between 6 to 12 months, those presenting between 6 to 12 months are also of monogenic etiology. It is a rare condition, incidence being 1 in 90 to 1 in 160,000 live births. So not a very old condition, first described about 30 years back. The first gene to be identified was PDX1 gene, which causes pancreatic agenesis, and the KCNJ11 and ABCC8 genes, which code the KIR 6.2 and the SUR1 subunits of the potassium ATP channel. They were identified just about 20 years back. Currently, mutations in more than 40 genes that regulate either the development of the pancreas or the insulin secretion or action, they have been identified. So our first case we identified in 2009, so just about 3 years after the ABCC8 gene was identified as causative, and this baby was started on glibenclamide, and now he's 15 years old, doing well. So coming to a little bit more about the pathogenesis. So these are single gene defects that act via either abnormal development of the pancreas. So that means that the transcription factor genes are affected. So either the whole pancreas could be absent, or there could be islet cell absence. So PDX1 defect is there, and then PTF1A mutation, which is also responsible for cerebellar neurogenesis. Remember that when we have transcription factor defects, many times we have multi-system issues, because more than one system that transcription factor may be important. So then we have decreased beta cell mass secondary to increased apoptosis, and here an important cause is insulin gene when it presents as heterozygous. So insulin gene is very interesting. It can cause neonatal diabetes as a heterozygous variant or as biallelic variant. When heterozygous, it causes permanent neonatal diabetes because it produces an abnormal kind of pre-proinsulin which gets misfolded and causes endoplasmic reticulum stress. But when it is a homozygous defect, actually it just leads to reduced insulin secretion, and therefore in homozygous state it actually causes transient neonatal diabetes. So beta cell dysfunction with reduced insulin secretion, most important are the channel defect, the potassium channel defect, KCNJ11 and ABCC8. Apart from that, insulin gene, when biallelic, and glucokinase. GCK, we know it's a very important cause of MODY, but when autosomal recessive, if both the parents are affected, then you can have a baby with neonatal diabetes, and this is responsive only to insulin. So, important thing to remember, all of you who would have worked with newborns know that in newborns hyperglycemia is not uncommon, and it is a common response to various stressors like sepsis, dehydration, hypoxia, surgery, and because of counter-regulatory hormones. Also iatrogenic high glucose infusion rates, which may be required especially in preterms and very low birth weight, then steroids, beta agonists, caffeine. So when there is hyperglycemia without known risk factors, if it is persistent or insulin dependent, then you should start thinking of neonatal diabetes. IUGR is common in babies with neonatal diabetes because insulin is important for fetal growth, and up to 50% present with diabetic ketoacidosis. HbA1c, should it be done or not? So if HbA1c is below 6.5, it does not exclude, but if it is above 6.5, it is a pointer to diabetes. So if we look at the pointers in various age groups, so in newborns, you have to think of neonatal diabetes if the hyperglycemia of above 250 milligram per deciliter persists for more than 7 days, or if there is even a single reading which is more than 1000 milligram per deciliter, or there is dependency on insulin to maintain euglycemia. Between 1 month to 6 months, all infants, you have to think of neonatal diabetes only. 6 to 12 months, those with negative autoimmune markers or those with other pointers. So I'll come to some syndromic causes of neonatal diabetes. So persistent diarrhea would indicate exocrine pancreatic insufficiency. Skeletal dysplasia may indicate IF2KK3 mutation, which is a common cause of neonatal diabetes. Exfoliative rash or hepatic dysfunction, they all point to different diagnoses, as I'll come to later in the presentation. More than 1 year, uncommon, but yes, some monogenic causes of diabetes present more than 1 year also. So especially if you have a sibling who is affected, or a prolonged honeymoon phase, or some syndromic presentation. So as I said, neonatal diabetes could be transient, that is in about 30% cases, and persistent in about, or permanent in about 70% cases. So if you look at the genetic etiology, TNDM or transient can be of two types. One, which is caused by abnormalities in 6q24 chromosome, and ZFP57 is also another important etiology. I'll come to it later. TNDM type 2 is because of, again, ABCC8 and KCNJ11 mutations, also HNF1B, which we all know is causative of MODY5. But even as autosomal dominant, it may be associated with a transient neonatal diabetes also. And again, INS gene, as I said, INS gene, if it is biallelic, it causes transient neonatal diabetes. Non-syndrome, permanent can be non-syndromic or syndromic. So in non-syndromic, most important are your potassium channel genes. Then you have insulin, GCK and IPF1. And in syndromic, you have either the transcription factor defects. Remember, as I said, transcription factors, typically they affect more than one organ and therefore syndromic presentation. Then immune response defect, FOXP3, which causes the IPEX syndrome. Then endoplasmic reticulum protein trafficking defect, in which IF2AK3 is very important, and then transmembrane channel regulator defect. Why I have written KCNJ11 and ABCC8 here also, because sometimes it may be associated with a syndrome called DEND. What is DEND? Developmental delay, epilepsy, and neonatal diabetes. Apart from that, some interesting syndromes like SLC19A2, which is causative of thiamine responsive megaloblastic anemia, and Fanconi-Bickel syndrome. Fanconi-Bickel is often, the neonatal diabetes part is often transient here. So what is the etiological profile? So as we all know, again, there is a lot of unknown genes which we don't have data on yet. So about 20% of patients may not have a genetic etiology identified. But when we look at, this is data from Exeter cohort, published about almost 10 years back, but it is still relevant because this is worldwide data. Exeter used to be the one lab where we all used to send samples. Now, of course, MDRF is the lab where I send all my samples for the last, I think, 8 to 10 years now, and they have been really helpful. So most of the cases that I will be showing here, they're all been diagnosed by Dr. Radha here. So, but this is the Exeter data, and here we see that if it is a non-consanguineous cohort, then these two, KCNJ11 and ABCC8, account for the majority. Whereas if it is a consanguineous cohort, then IF2AK3 is the most important gene. And the other two, ABCC8 and KCNJ11, are less common. So always ask history of consanguinity, family history. Now, just a quick look at this picture where we are seeing the mechanism of neonatal diabetes in potassium channel defects. So I'll begin from here. In the resting stage, this is the potassium channel. So remember that this potassium channel is a leaky channel. So continuously potassium comes out, and this maintains the cell in a polarized state. So if there, normally when glucose enters, then by metabolism ATP is generated, and this is ATP sensitive, so it closes. When it closes, the cell depolarizes, leading to influx of calcium and insulin exocytosis. So what kind of mutations will lead to neonatal diabetes? Activating. Activating means that the channel remains open. And what kind of mutations will cause CHI? Inactivating mutations. So important causes of syndromic neonatal diabetes: Wolcott-Rallison syndrome, which is caused by IF2AK3 gene defect. What are the syndromic presentations? It has skeletal dysplasia, but remember that it presents later, around 18 to 20 months, whereas diabetes onset is around 3 months. So you don't have to wait for these syndromic features to appear. Episodic liver failure is an important problem with this, and in fact it is the leading cause of morbidity and mortality in these patients. Then another important syndrome is Fanconi-Bickel syndrome, which is, as we all know, generalized proximal renal tubular dysfunction, hepatomegaly, and rickets. Again, this may be transient. IPEX is immune dysregulation, polyendocrinopathy, enteropathy. So patients typically have eczema, they have diarrhea, and they may have autoantibodies. So it's autoantibody positive but monogenic. Then TRMA, also known as Rogers syndrome. It is characterized by the triad of megaloblastic anemia, diabetes, and sensory neural hearing loss. Apart from that, abnormal hematopoiesis is also there. And onset can be between infancy to as late as adolescence. So although it is classified as NDM, the presentation can be late. So in the first case that I had showed, baby presenting at 6 weeks with a family history of a previous sibling affected, he turned out to have this IF2AK3 homozygous mutation. So this is a recent paper from Liver International 2024, where they have looked at 118 patients with this mutation, and they have described that the median age of presentation was around 2.5 months. And besides neonatal diabetes, what are the important present clinical features? Liver involvement and impaired growth in 70%, skeletal abnormalities in 60%, and various other abnormalities also present. And the median survival, 10-year survival, is as low as 53%, with liver failure being the leading cause of death. And therefore, people have actually, several investigators have tried doing an anticipatory liver transplant as well. in these patients, and liver transplant can actually improve the prognosis. So coming to another case, this was a 6-month-old girl. We saw her about 8-9 months back, and she presented with an acute complaint of fever, cough for 5 days, loose stool, fast breathing for 1 day. She first went to another facility and noted to have severe anemia, hemoglobin of 2 grams per deciliter, random blood sugar more than 500. She was a term baby, first offspring of consanguineous couple, but she was not low birth weight. Interestingly, her birth weight was normal to high, but currently she had failure to thrive. She had severe decay when she came to us. She was given transfusion and then ketosis was corrected. Baby developed hypernatremia and hyperchloremic metabolic acidosis. Again, she had drop in hemoglobin and platelet. So what are the possibilities when you see such a sick baby presenting like this? Anemia is there, all cell lines are depressed. Sepsis remains one important possibility, and sepsis we know can be associated with hyperglycemia, sometimes even with decay-like presentation. Organic acidemia remains another possibility. But here we also see that we did all that workup. Finally, what we found was that we thought that in view of the anemia, which was actually megaloblastic, we thought of thiamine responsive megaloblastic anemia. So we did a BERA, and BERA also showed severe profound bilateral sensory hearing loss. And yes, we did find a mutation in SLC19A2, but even prior to getting the mutation, we started her on thiamine. And the baby responded very nicely. We could stop the insulin and send the baby home. With thiamine itself, her sugars improved, her hematopoietic parameters also improved, and she was off any transfusion requirement. So response to thiamine, again, there is a nice paper. So I'll just summarize that basically if you start thiamine early in the course of the disease, then the response is the best. If you diagnose it, somebody has already diagnosed diabetes and then the child presents to you after receiving insulin for a few years or 2 to 3 years, then we don't see such a good response. Coming to transient neonatal diabetes. So in transient, IUGR is more common. The presentation is typically earlier as compared to permanent neonatal diabetes. So they typically present within first few days to weeks of life. And umbilical hernia may be a marker. The diabetes resolves within a few weeks to months, but may show either permanent remission or hyperglycemia during illness, or recur mimicking type 2 diabetes in adolescence or during pregnancy. So even though the diabetes resolves, you have to keep them in follow-up, which is very, very important. And typically they are managed with insulin when they present in neonatal period and sulfonylurea when they present in later on in adolescence. So the molecular defects in TNDM are very different. Like the most important ones, in more than 70%, it is because of overexpression of the 6q24 imprinted chromosomal region. So the 6q24 has 2 important imprinted genes, the PLAGL1 and HYMI, and these are maternally imprinted, only paternally expressed. So you can have different mechanisms where you can have overexpression. Either it could be uniparental disomy from the father, or it could be duplication of these 2 genes in the father, or it could be that there is overexpression of or loss of imprinting of the maternal region. So only one of these is autosomal dominant. Which one? Where you have duplication of the father's thing, because everything else is like a de novo event which can occur during meiosis. But if there is a duplication of these regions in the father's gene, then the father will transmit it as autosomal dominant to all offspring. So therefore genetics and identifying the exact cause is important. Similarly, for ZFP57, ZFP57 is an autosomal recessive inherited gene. It codes for transcription factor which is required for methylation of several genes. So it causes hypomethylation and therefore loss of imprinting in general. Okay. Coming to permanent neonatal diabetes, it requires lifelong treatment. Typical median age at presentation is about 3 to 8 weeks. Mean birth weight is not as low as in transient neonatal diabetes, with the birth weight between 10th to 25th centile. And about 50 to 60% are caused by KCNJ11 or ABCC8, and therefore they are responsive to sulfonylurea treatment, while the rest need permanent insulin treatment. We discussed briefly about DEND. So why is there an association with DEND? Although thankfully it is in a small proportion. Majority of patients do not have any developmental abnormalities. Few have some minor neurocognitive defects which you can pick up, but very severe can present in a few cases. So let me quickly go through another case. A 4-month-old female baby, second born to non-consanguineous couple with one normal child. Antenatally, oligohydramnios was there. Baby was born as term IUGR with a low birth weight, and she presented to a hospital at Ranchi with the complaints of fast breathing, increased urine output, and fever. Was found to have mild DKA, managed, and then subsequently sent to us. So when she came to us about 1 month after diagnosis. 4 months she was diagnosed. So remember, I forgot to mention earlier, ABCC8 and KCNJ11, they are both autosomal dominant, they are both heterozygous. So either autosomal dominant or sporadic. Most of the cases in fact are sporadic. So that is why they're more common in non-consanguineous cohort. So this baby did not have any dysmorphism but had multiple episodes of seizures in the past 1 month. Query due to hypos but not very clear what was the reason. She had been on insulin. And there was regression of milestones. Baby was not even holding her head when she came to us. On ultrasound, pancreas was normal, thyroid function was normal. Initially, we managed her on glargine and Humalog insulin, but very erratic control was there. We thought that there is a possibility of DEND, and even before we got the mutation report, we started her on sulfonylurea, glibenclamide. How do you start? You start with 0.1 mg per kg. BD, and then you increase gradually to up to 0.5 mg per kg BD, and simultaneously you bring down your insulin doses. So we were able to stop insulin in this baby on 4th day, and actually now it's been about 4 weeks. She has started improving in her developmental milestones as well, and we did find a heterozygous KCNJ11 mutation. Parents were normal. So this was the CGMS record on insulin, and this was the record on sulfonylurea. So you see a very, very dramatic change with sulfonylurea, no hypo, no hyper. Why? Because it's acting very physiologically. How does sulfonylurea act? It acts on the SUR1 region and it keeps the channel open. So clinical presentation can give a clue to the underlying genetic defect. So DKA, whereas it is found in more than 75% of patients with mutation in KCNJ11 or ABCC8, it is not seen in those with transient neonatal diabetes due to 6q24. Malabsorptive diarrhea indicates exocrine pancreatic insufficiency. So think of GATA6, IF2AK3, PTF1A. Other extra pancreatic findings, polycystic kidney disease could indicate HNF1 beta, as I told you, it's a MOTI gene but can present as neonatal diabetes. Neurological abnormalities, DEND syndrome, neuro D1, immune dysregulation with IPEX, hypothyroidism with GLIS3, which is again a transcription factor, deafness associated with Wolfram syndrome, and SLC19A2. Skeletal abnormalities, spondyloepiphyseal dysplasia is associated with your IF2AK3 mutation, but it typically presents late. And hepatic dysfunction also with various genes. So head-to-toe examination can actually give you a good clue. For example, if you look at the umbilical hernia or exomphalos, it could indicate transient neonatal diabetes. Macroglossia indicates transient neonatal diabetes. Then autoimmune thyroid disease could be because of FOXP3 mutation. Rickets and hypophosphatemia should tell you that it could be Fanconi-Bickel. So genetic testing in the era of NGS, now of course, clinical phenotyping is very, very, very important. But as I said, some manifestations evolve over time. So now in all babies less than 6 months, you can go for NGS directly, non-selective, and the genetic diagnosis will predict the evolution and the other features that you can think of encountering, and you keep on being vigilant for those. Like in the baby 6 weeks old that